Hello, my name is Ali. Welcome to XMed Education channel, and I'm gonna have another video of physiology of heart. In this video I'm gonna talk about the ECG. I know how hard is ECG and how challenging it is for some of you guys, but I promise you in this video I make it as easy as possible and make it enjoyable for you guys. So you just need to subscribe to my channel and support me, and I will definitely make more video. Thank you very much, and let's start. So the first question is, what the hell is ECG? Like, what is this? What is these lines? What is these graphs? I'm gonna explain you. First we have to talk about the basic of ECG, then we're gonna talk about the heart vectors and what is this, like heart vectors in general. Then I'm gonna talk about the Einthoven leads. Then we have topic about the P-QRS structure. I explain it in detail every part. And then we have Goldberger augmented leads, and then Wilson precordial leads, and in the end I'll give you a brief summary of what we explain, and I am gonna show you ECG paper and you will understand how easy is the ECG. So let's go. First, basic of ECG. I know probably you're not gonna have this part, but it's like nothing. I'm gonna explain it. So first, ECG is analyzing the cardiac impulses by recording the electric potential on the surface of the body. So we put some stuff on our skin and we can detect where is the heart, what is the rhythm of the heart, how is the blood supply of the heart, and what is the electrolyte. That's pretty impressive. Just imagine with something non-invasive and very cheap we can get this much information from our heart, which is inside, and now we have no idea how it works. So I mean, like, without this ECG. So now I'm gonna explain in a cell level. At the cell level we have cells that they are in resting position. So as you see, like, they are in a resting position, nothing happening, but like when there is a pulse coming, like there is an action potential started, depolarization. These positive ions which is outside the cell goes inside and they start depolarizing cell, and they go through this like cell by cell to pass this depolarization and make a contraction inside the heart. So they go cell by cell like this pattern, and in the final all the fibers will be depolarized, like all the cell will be depolarized, and they make a vector that I'm gonna explain you in future slides. Then we have repolarization, but you have to know this repolarization will happen in two ways. So look at this picture. In this picture, as you see, first we have endocardium, which is inside the heart, and we have epicardium. Depolarization starts from the endocardium of, for example, ventricle, and they go to the outside the heart, which is epicardium. So depolarization starts from inside the heart and they go outside the heart to the surface of the heart. And repolarization happen in the opposite way. So repolarization happen from the cells that activated later, and so they start to repolarize and they go back. As you see, like in this fiber, depolarization happened, then repolarization, as you see in 4b, happened from this way. So the repolarization of the skeleton cell is this way, but repolarization in cardiac cell is from that way. So they go from this way to this. The result that I explain is depolarization from endocardium to epicardium and repolarization from epicardium to endocardium. That's the basic you need to know before we go through the ECG patterns. So heart vectors. This depolarization and repolarization that we explain is all to understand this basic physics. Believe me, this is very basic. You don't need to know, you don't need to have a deep knowledge of physics to understand them. So look at them as a cell. Each cell can make some action potentials. These cells, if they are in same direction, like this, they act like a vector. If it's in this direction and the other cell is in the same direction, the sum of these two vectors will be something bigger. The this one plus this one, the first vector plus the second vector will be something longer. But if the first cell is depolarizing and the second cell is repolarizing, the sum of them will be zero. Look, like the first one is in right direction, the other one is in the left direction. So this one plus this one will be zero because this is positive, this is negative. And but like in the heart, there are many different path of direction as the muscle are in different directions. So in heart, we actually have something like this. I will explain you later how they work. And these vectors direction, these heart vectors, you see like each one of these count as single vector, but when they all come together, they make the heart vector, like one of these vectors that shows the general direction of the contraction of the heart in one moment. So these vectors change at every moment. That's why in ECG we have different patterns. So at 1 second, the whole heart gonna have one vectors that we can see it from different perspective. I'm gonna explain it later. So first, in the heart, what's going to happen? Atrial depolarization. How they go? The direction is important. The direction is from the SA node to AV node. The direction is something like this. Then the ventricular depolarization. Ventricular depolarization is from left side to right side, as you see second here. Then in the septum, between two ventricles, it's toward the apex of the heart. So from this part, they go to the apex of the heart. Then we have when they arrive to the wall of the ventricles, they go from the endocardium to epicardium that I explained in previous slide. And in the end, we have left ventricle contraction, which the vector gonna be from to the posterior basal of the heart, like from the posterior side of the heart to the base of the heart. Here is the base, here is the apex. So let's go, and now I think we know all the details that we need, and we can talk about the more serious things like Einthoven, leads, and triangle. I know you guys probably saw this triangle in your first year of medical school, or like you saw it somewhere. Now I'm gonna explain you what are they. Before that we start to talk about these leads, you have to know that we have a blue vector, which is this one. Like I draw it in a blue color to explain you about the atrial depolarization. As you know, atrium is much smaller than ventricle, and their muscle is much weaker than ventricle, so their depolarization gonna be smaller, so the magnitude will be much smaller. Then we have this red vector. This red vector is ventricular depolarization. Ventricle have very strong muscle. They want to pump blood through the heart, so their vector should be much larger. And then we have the ventricular repolarization. Why ventricular repolarization is smaller than ventricular depolarization? They both have the same muscle. The thing is, the depolarization is much longer than repolarization. That's the reason. And why there is no vector for atrial repolarization? Because they overlap with ventricular depolarization. Why? Because when the atrial depolarization happen, the signals, the pulses go to the ventricle, and ventricle start to depolarizing right after the atrium depolarization. So the atrial repolarization will be overlap with the ventricular depolarization, which is much bigger. So we can see the atrial repolarization, which is very small. So What is the relationship with Einthoven leads and triangle and all the things that we explain? What is the relationship between these two? Before we start, look at this picture on the left side below the slide. You see a lead 1, you see a lead 2, you see a lead 3. What are these? So when we want to see the direction of the vectors, we put 3 leads on the body. 1 on the left side, left arm, 1 on the right side, right arm, and 1 on the left leg. So they are 3 direction and they make a triangle. So when they make a triangle, we call the one that goes from this side to this side, we call it lead 1. The other one that goes from the right arm to the left leg, we call it lead 2. And the one that goes from left arm to the left leg, we call it lead 3. So when we put these 3 leads on different parts of the body, they're gonna be vector. They're gonna be a vector for each one of these, like 2 electrodes, like 1 electrode right arm, left arm, 1 electrode right arm, left leg. So they're gonna be like vectors for all of them. Let me explain in another picture. For example, at the contraction of the ventricle, they're gonna be, it's just an example, they're gonna be one vector which is this way. These vectors show something like this on lead 1. This vector shows something like this on the lead 2, and same vector shows something like this on the lead 3. What does it mean? Make it easier for me, Ali. So just imagine that I put my hand like this. So you see it from the front picture. When you see it from the front picture, you just see here. If I ask you, do I have a what is the color of my nails? You can't tell me what is the color of my nails. You have to have this picture from this side. For example, when you broke your leg, you go to the X-ray room. They take a 2 picture, one from inferior, one from the anterior side, one from the lateral side, to see the all aspect of your heart. This is the same. These are actually showing the picture of this electrical vector from different perspective. For example, from the perspective on opposite side of this vector, you see a small, very small, like you see it's just this small vector that happened on lead 1. So this is pretty small. But on lead 2, you see like this is much bigger, and in the other side this is also something close to this one. So different leads show different perspective, and when they come to, when we get something like, if I want to explain the vectors of the ventricle and atrium and like their depolarization and repolarization, the picture that we take from each leads give us something like this. As we put name for them, P wave is for depolarization of the atrium, QRS is for depolarization of the ventricle, and T wave, which is this one, is for repolarization of the ventricle. And we have one for this lead, the lead 2, one for lead 1, and one for lead 3, that they just show different perspective of the same things that happening in 1 second. So now we know them. There is one law that you have to know, is that the lead 1 potential plus lead 3, lead 1 plus lead 3 will be lead 2. This is a law that if you saw them, for example, this one is the lead 1 is has a very small amplitude. The lead 3 has a bit bigger amplitude, and lead 2 is the lead 1 plus lead 2. It's like bigger than both of them. This is just a law, and you have to know that Einthoven triangle is based on bipolar leads. What is bipolar leads mean? Bipolar means that there is one positive side and one negative side. Both electrodes get some electrical pulses. But when we have unipolar, there is one electrode and one reference. So the reference doesn't actually count any electrical activity. It just acts as a reference to compare it with the other electrode. So Einthoven leads, which called lead like 1, 2, 3 in this shape, like 1, 2, 3, 3 in Greek type. I don't know if it, yeah, it's Greek type. So they call it Einthoven leads. Let's go and see more. I'm sure that in this picture, now that I talked about the vectors, this picture helps you to understand completely what does this contraction and what does this leads and vectors means. So first, when the contraction, just imagine we have the lead 2. So when the contraction happened, the first lead that the first vector that we see inside the heart, the total, it's gonna be the total of all these small vectors inside every cell. So the total of them will be the heart vector of number 1. So it is the opposite side of this negative and positive. So it goes down a bit when the contraction is from the septum. Then we go to the second, the contraction go further, and the direction will be this way. Direction of all the cell will be this, like as I explained in septum, they are all toward the base of the heart. So we have another lead which is very strong because there are the large number of the muscle, and the depolarization is very strong. As you see, this goes up very fast. So first we have Q, then we have R, and then the contraction go further, and the direction will be changed. The direction will be this way, but the picture that we have is from here to here. So they show this as something like this. They comes down, and in the fourth one, which the posterior basal, as I explained, is the opposite way, and the S part of the QRS will be happen. If you still didn't understand it, I have a surprise for you. Look at this picture and you definitely understand. So contraction starts from here, and they go further to all part of the heart. So as you see here, we have the most muscle of the like the biggest number of muscle toward the base, and the whole part of this QRS is just the contraction of the ventricle, depolarization of the ventricle. And I think now it's supposed to be clear. Let's go. So now that we know all of these P, QRS, and T, now we know P is depolarization of the atrium, QRS is depolarization of the ventricle, and T wave is repolarization of the ventricle. And we know that each lead is gonna have some, like one of these. But like, what is this now? What can we understand from this section? From this section, we get many data. For example, P wave, we have P wave here. P wave shows the function of the atrium, function of the contraction of the atrium, function of the conduction of the atrium pulses. So from the P to R, we can see how fast this contraction is. We have some original number, for example, 0.16 second, that it's that is between like P to Q, and it shows the depolarization time of the atrium. Then we have QRS. The QRS, we have to know how wide is it. Is it narrow? Is it wide? If it's narrow, it means something. If it's wide, it means another disease. And there is another measurement from Q to T, and there is one ST part. All of them, they have a meaning. And the other factor that you need to know is from R to R, from each R. For example, this is one bit. This is one depolarization and repolarization. This is another depolarization, another repolarization. So from each R to R, we can detect the heart rate. So we can calculate the heart rate from the distance of this RR interval. RR interval means between two depolarization. And the other factor is that with our inspiration and expiration, the frequency of heart rate will be changed. Why? Because of the vagus nerve. Vagus nerve can be, which is representative of the parasympathetic nervous system on the heart, and with inspiration and expiration, they can affect on the vagus nerve, and they can increase and decrease the heart rate. So if you inspire, the frequency of the heart rate go up, and with expiration the frequency goes down. And what data we can get from ECG? So if there is a ST elevation here, if there is any ST elevation, it means that there is a problem with blood supply of the heart. Some part of the heart depends on the lead. So, and we call it myocardial infarction. So when you see something is like going up here, it shows the sign of the myocardial infarction. The PR will show if there is any block. For example, as I mentioned, this is the atrium, and in the atrium, from the SA nodes, pulses go to the AV node, and if there is any block in the AV node, this R, they don't say actually PQ, they count it from P to R. This PR interval will be longer or will be changed. It depends on type of the block. You guys studied these things in pathophysiology in third year. And the QRS, if it's wide or narrow, it shows some branches block. The branches like bundle of his, after that we have two branches, right and left. If there is any block, there will be like narrowing or widening of the QRS. Then we have like QT. If the QT is longer, then somehow there will be QT syndrome, which is very dangerous, and it can be congenital in some people. So there are some congenital diseases that they can long QT syndrome. There are some drugs that they can cause long QT syndromes, and you will study it when you are in your pharmacology class or when you are in your rotation in internal medicine. So the next thing that we have to know is heart axis. What is this heart axis? The heart axis is actually the heart vector that comes, like I explained, that there is a one heart vector that shows the total vector of all cells inside the heart. This vector, the degree between the horizontal pattern to this vector called alpha. This is the axis. That's this easy. You don't need to make it hard for yourself. You don't need to make it like anything special for yourself. This is that much easy, and you don't need to be worried about it. And we can calculate this axis by the size of these QR complexes in each lead, and this is for your third year during your pathophysiology classes. But what you have to know is that if it's from 0 to 90 degree and mostly from 30 to 60 degree, it counts as a normal vector, heart vector, or normal alpha degree. But if it's more than 90 degree to 180 degree, they call it right axis deviation. It means that this axis deviated to the right side, which not supposed to be in a normal person. So if the ECG show that there is a right axis deviation, probably there is something wrong with the heart. The other one is from -30 to -90. This is left axis deviation. And if it's like from -90 to 180, which is exactly the opposite of the normal range, there will be extreme deviation, which we call it extreme deviation. It depends if it's more toward the right side or left side. They have different name that you don't need to know for your physiology. So for understanding the heart, having just those 3 leads in like lead 1, 2, 3 is not enough. We need other leads as well to have a better understanding of the heart. So just imagine you have one person in the middle and we have 3, like one mirror here, one mirror here, and one mirror here. Or it's better to have like mirror from all the side. These leads actually give us more picture of the heart, picture from all perspective of heart, so we can have a better understanding of the heart. The second lead, which is unipolar. Unipolar means they are comparing with the reference point. There is no two electrolyte to compare them to each other, and we show them as a V, and it can be like AVR if it's right side, AVL if it's left side, and AVF if it's toward the leg, like foot. So and how we can calculate them. This is lead 1, this is lead 2, and this is lead 3. AVL is perpendicular to lead 2. AVR is perpendicular to lead 3, and AVF is perpendicular to lead 1. So this is how they actually works in this system, and in their name, A stands for augmented and V stand for unipolar. So how the picture of this AVR, for example, look like? In lead 2, for example, in lead 2, this is from the direction is from the right arm to the left leg, and the vector will be something like this. But when we talk about the AVR, which is toward the right arm, the amplitude is quite same, but in a different direction. So lead 2 shows the direction on the upside, and AVR, which is here, show the direction on the opposite side. They give us the same information, but from different perspective. That's it. It's not something different. These two shows exactly same thing, but from different views. That's it. So they are kind of mirror to each other, like lead 2 and AVR. So now we understand about 2 different leads type: Einthoven, which is 1, 2, 3, and Goldberger leads, which are AVR, AVL, and AVF. So if we count all of these together, we have view from every 30 degree of the heart, like from every 30 degree. See, we have one here, one here, one here, one here, one here, and one there. So all together, every 30 degree, we have a picture of the heart in the front plane. But front plane is not enough. We need another view as well that we're gonna explain it. Let's go. Wilson's precordial leads. This is how we're gonna have another view in a transverse plane. So in a transverse plane, we need another view to see each different part of the heart, and they are very close to the chest, so they can give a great information. In normal ECG, when we want to take a ECG in a normal person, without like just normal normal ECG, I am gonna explain what is like abnormal ECG. They gonna check 6.6 leads, and they put it on the chest. They put from the anterior part of the chest, and they go all the way to the lateral from 1 to 6. These leads record mainly the electrical potential of the cardiac musculature immediately under this electrode. So when we put it here, they exactly show the electrical potential on that side, on that view, and in another plane as it's transfer. So one of them shows from this way, the other one show from this perspective, the other show from this perspective, and V4, V5, V6. I said there is another type when there is a problem with the posterior part of the heart. If there is a problem with the posterior of the heart, they put more leads. They put leads like 7, 8, 9, because this lead 7, 8, 9 can give a better view of the posterior surface of the heart. The V1 give a perspective from this side. I explain it later. And V2 another view, V3 another view, and they have an overlap because they are very close. Let's go and see the summary of my ECG video. So this graph, I put it in summary because it's very important, and please memorize it. You need this in your 3rd year, in your 4th year, in your 5th year, and when you are a medical doctor, you need to know these numbers. PR is from 0.12 to 0.2 second. QT is like, I'm not gonna like explain, like read all of them. You guys can just read them, and this is very important. And as you see, QRS is pretty fast as 0.09 second. So I explained that each lead shows one perspective of the heart. For example, in lead 1, we can see lateral wall of the heart. In lead 2, we can see the inferior wall of the heart. In lead 3, we can see inferior. So 2 and 3, they both show inferior wall. AVR, it's not a specific view. AVF is a lateral wall. AVL is inferior wall, and V-wall is septal wall. V2 septal wall. V3 anterior wall, and you can read all of them. And why is that? So we have, for example, in case of blood supply, you guys study in anatomy that we have like LAD artery, like right coronary artery, left coronary artery, and different type of artery around the heart. And if any of this artery blocked by any plaque, for example, atherosclerosis plaque, they can stop supplying that muscle in like one part of the heart. This QRS from different perspective can exactly show which part of the heart doesn't have enough supply. Why? Because, for example, if there is a necrosis in the wall of the heart, for example, in lateral wall of the heart, the vectors from the endocardium to epicardium will not be that strong as before, or it's even changed. So the heart vector will be changed, and they show some different in the ECG. And what is this picture? This is the final things. We have lead 1, lead 2, lead 3. This is the exact picture that you see in your clinical rotation. Lead 1, for example, show QRS. They have T wave, they have P, they have PR interval, they have QT interval, again another P, and from R, you can see that they are all in same pattern, so they are rhythmic. If they are there is any arrhythmia, they're not gonna be on same size. Then you can have a feature of like if it's narrow or wide, and we can get different perspective from this ECG. This ECG is like a picture. It's like picture from different view. For example, if my nose has, like if my nose had a curve, if I was looking at you in front way, you couldn't see like a small curve on my nose. But if I'm gonna put my face on lateral position, if I have any curve on my nose, you will see it. This is exactly same. This gives view from different perspective to see any problems inside the heart. Thank you for watching my video, and I show you guys this video before, and in the end I want to say, do what you have to do until you can do what you want to do. Thank you for watching this video. I wish you all the best. Please subscribe to XMed Education, like my video, write a comment for me, and let me know how I can improve my videos, and this definitely inspired me to make some more videos. Thank you very much, and have a nice